voice. There is no voice يا خالد. خالد there is no voice. مش سامعين voice لخالد؟ سامعين voice خالد؟
انميوت يا خالد معلش بعد اذنك.
خالد مفيش صوت يا خالد.
لا مش سامع صوت خالص.
خالد حسك مش جاي عندنا يا خالد. انت لابس سماعات وعامل فيها
شغال بالسماعه مش فول فيكسد.
نعم. لا ما هو ايوه كده، شيل السماعات وخليك بلدي زينا كده. ازيك دكتور مجدي؟
ازيك يا معالي الباشا استاذنا العظيم دكتور ابراهيم بيه؟ ازي الصحه يا باشا؟ وحشنا يا بيه والله. ازي الصحه يا فندم؟ الله يخليك. ربنا
احنا مش سامعينك يا خالد خالص، مش سامعينك خالص يا خالد. انت بتتكلم ده احنا مش سامعينك خالص يا خالد. راح منك دقيقه على الفاضي دلوقتي انت اهو. في حاجه في الحس يا خالد. انت سامعين حاجه يا دكتور حسين؟
كان المفروض ليكشر افضل.
دكتور حسين سامعين حاجه؟
لا يا فندم.
لا ما فيش صوت، مش
واصل خالص حاجه بيه خالص.
مفيش حس. دكتور عزت معانا لسه؟ دكتور عزت؟ لا عزت مش دكتور مجدي اللي معانا. ازيك دكتور مجدي؟
ايوه بيه مع سعادتك يا باشا. ازي الصحه بيه؟ ازي الصحه يا باشا؟
دكتور مجدي طنطا، مجدي حجازي.
لا الدكتور حجازي، محمد حجازي معاك يا بيه.
اهلا ازيك يا باشا؟
ازي حضرتك؟ منور يا دكتور ابراهيم. منور يا باشا.
هو ممكن يا بيه يبعتوا على الواتس.
طيب
ونيكست سبيكر
يتكلم. دكتور خالد احنا هنستنى عليك شويه. هنخش على الدكتور اللهيبي. الدكتور اللهيبي برضه one of the eminent gastroenterology في السعوديه. الدكتور اللهيبي it's very pioneer في اليو اس. he do all the techniques. راجل اساسا ذو اخلاقيات عاليه جدا جدا، سواء في كل حته الحقيقه بنقابله فيها. وصديق عزيز جدا، ومن الناس اللي ستار على مستوى حتى مش بس السعوديه، على مستوى الميدل ايست والعالم. هي از فيري فيت. انا شفت خالد من 7-8 سنين بيقدم حاله كانت او اكثر يمكن على اليو اس درينج، وقالوا لي شاوروا لي عليه الدكتور عبد الرحمن جبريل، وقال لي خلي بالك من الدكتور اللي ده هيبقى بايونير. فالحقيقه بقى بايونير جامد جدا. الدكتور عبد الله ابديت مانجمنت اوف بانكرياتيك فلويد كولكشن. اتفضل لغايه ما الدكتور يكمل. اتفضل يا بيه.
حبيبي السلام عليكم.
عليكم السلام.
شكرا يا بروف. وانا بصراحه يعني it's my pleasure today to present and to participate. وحبيبنا بروف ابراهيم استاذنا وتعلمنا كثير. Today we'll talk about the update management of pancreatic fluid collection, and mainly I will talk about the world of necrosis. So this is the objective. So we'll talk mainly about the importance of the Atlanta classifications for also I will touch on the pre-procedure evaluations, mainly in imaging. And number 3, usually we have a lot of debates about the timing of the interventions, okay? Finally, I will end my presentation by the management of world of necrosis and also the post-intervention or procedure care. Everybody aware about this study is almost was updated and revised on it 2012. And this is one of the things we have to consider in our practice and as a classification and also as a terminology, and we have to use it. As you see, they divided the acute pancreatitis to the edematous pancreatitis and necrotic pancreatitis. And the most common usually edematous, 85% to 15%. If you see the subsequence of the edematous pancreatitis, usually they present by acute fluid collections. Finally, those patients, sometimes they will be ended with the pseudocyst, and usually the percentage from 10 to 20%. So those usually, if you want to drain them, you have to consider the infection symptoms, and also there is obstructions. If you move to the necrotizing pancreatitis, the necrotizing pancreatitis is one of the difficult, challenging, usually depends on the patient. Sometimes you see a simple necrotizing and with the severe necrotizing. And usually the first fluid collection with the necrotizing is called acute necrotic collections in acute phase, and the duration usually less and more than 4 weeks. If it's more than 4 weeks, then it will form a wall of necrosis. And most of the acute necrotic collections, 90% they will have wall of necrosis, and you have to consider treating those patients. At the same time, you have to consider the durations, more than 4 weeks or less than 4 weeks. And at the same time, this duration gives us a maturity of the wall to drain it safely without any complications. With those maturity, also the content of the cyst is very important. Is it a fluid or a fluid with necrosis? If it's a fluid only, this is most likely with a pseudocyst. If you have a fluid and necrosis, usually toward the wall of necrosis. As you see, this is one of the things to consider imaging. The imaging, most of the people and most of the recommendation, they recommend to use the MRI and MRCP before the drainage. And why they favor it? They favor MRI and they don't prefer to do CT scan, because MRI and or secretin MRCP is good for solid component and also for necrosis, and the sensitivity is very high to detect the necrosis. Almost here, as you see in this all the studies, 100% compared to the CT scan, 25%. With a guideline, with the European endoscopy guideline, they suggest to do MRI and secretin MRCP before the drainage to give us also more informations. What are these informations? It can give us more information about the pancreatic duct. You can tell if you have disconnected duct syndrome, of etiology also, if you have a stone in the CBD, of also some, most of the patient, they have pseudocysts, and this is one of the risky procedures. So the MRI will tell us, and if you have aneurysm, probably you have to treat the aneurysm first. One of the important things, you have to know the natural course of those collection and the timing of wall of necrosis. It's okay. So most of those collection, 40%, they will have spontaneously resolved without any intervention within 6 and 12 weeks. So that's why you have to give a time for more than 4 weeks. And also the rule of the 4 weeks, it came from the old study of the surgical literature, and they consider those patients to have a wall of necrosis to form a very good wall to drain at the same time, it decrease the mortality and morbidity if they want to do necrosectomy of more than 4 weeks. But as you see nowadays, people, they consider those patients to be drained less than 4 weeks. This is one of the clear studies, randomized studies. As you see here, they compare those early drainage less than 4 weeks and versus the standard drainage more than 4 weeks. And they conclude in these studies, you can drain those patients with early than or less than 4 weeks if those patients, they are very sick and they have infections and they have multiple organ failure. At the same time, no need to do necrosectomy, and you have to consider only drainage is enough. And also at the same times, also they reported that there is no increase in the complication related to the procedure. If you restrict to the Atlanta classification, is still considered the standards, and so more than 4 weeks, less mortality, less hospital stay, and also less ICU stay for the standard patient without any infections or multi-organ failure. How to manage those patients? A lot of difference. So you have to prepare the patient. You don't have any contraindication. You have to make sure about anticoagulations. And then you drain the patient. Once you drain the patient, and then you think about to do necrosectomy endoscopically, or maybe you enough drainage to can treat the patient, and then you have to follow the patient after you drain it. We have multiple ways, either plastic stents or the variety of lamps to treat those patients, or plastic or multiple plastic stents. As you see the standards here, usually have a multi-steps or have a single step access. Is a single with the lamps with the metallic stent, which is like either hot or non-hot metallic stent, or multiple with the plastic. As you see here, this is the standard. We puncture the cyst and we put the wire, we advance the wire, and once we have the access, we have to dilate with the balloon, and then we insert 2 or 1 plastic stent, or you can also insert non-hot fully covered stent. The problem with those procedures, you perform a lot of steps. It has some of risk, leaking, perforations, bleeding, or displacement of the stent. Or maybe you have a single step access for difficult patients. Okay, now if you came in evaluation, usually US is preferable because you give more evaluation, you can evaluate the contact of the stomach. If you can avoid any vascular, you have a vascular puncture. So to drain it with a plastic stents or metallic stent, this is the big debate now. See, is it multiple pigtails or plastic stent, or plastic stents or metallic or lamps, hot or non-hot lamps. As you see in this patient, this first step, we punctured the cyst or the wall of necrosis. As a clear, this is one of the aspirations. So you have to aspirate the fluid. After that, you insert the wire. Once you make sure you are in the wire, then you have to follow it by the cystotome to have a bigger or clear access. After that, once you finish, you have to make sure about the access, and you have to dilate it using the balloon. Finally, you have to place one of the plastic stent or multiple. So you see, as a multiple step, if you compare it to the standard, to the new modality, which is the lamps, as you see, is only puncture the cyst, single access, easy, time usually less, and you have to open inside the cyst. Finally, you have to withdraw, and then you clearly have the distal part inside the cyst and the other element in the stomach, and you see the necrosis out of the stent. Now, as you see, they compare to the modality. This is a randomized trial comparing the plastic versus metallic. This is from the Florida group, and they see there is no difference in the success, hospital stay, lamps more adverse events more than plastic, are more expensive and usually quicker, so there is no any preference. In the same times, we have another study, systemic review with the meta-analysis. It gave us totally different conclusions. So they prefer the metallic stent is superior to the over the plastic for wall of necrosis, for the resolution of the collections, less bleeding. As we know, sometimes we consider the bleeding more with the metallic, but this study showed clearly bleeding more with the plastic, and also less occlusion and complications also less. So there is two studies almost contradicting the results. But as you see, this is the guideline or clinical practice update. This year was published, and they prefer also the metallic stent for those patients or for the kind of the patient. Then once you drain it, you have to think about necrosectomy. We have two ways of necrosectomy. Either you can do passive indirect, or you do active direct necrosectomy. Passive means that you drain the patient and you leave it and you follow it clinically, and then you have to follow the patient clinically with imaging and you see the resolution. Active means you have to go to do endoscopic necrosectomy. As you see also here, also AGA clinical practice update, they prefer to wait and then to consider necrosectomy if the patient not responding to the endoscopic transmural drainage. As you see, this is the all surgical. So most of the study now again is the surgical necrosectomy that they prefer endoscopic necrosectomy. As you see, this is some of the indirect way, and this is the direct way. As you see, this one a big trial, two trial, tension trial and Mazir trial. So they have clearly stated that they prefer the endoscopic. The endoscopic is better, and then the mortality is less, million complications less with the endoscopic method. So they prefer to go endoscopic step up approach, non-surgical step up approach with the percutaneous. As you see, this is one of the things, usually less complication, less pancreatic fistula, shorter hospital stay, and also better quality of life. And sometimes the cost is very less cost compared to the surgical. As you see, this is one of our patients. So it was very difficult and large collections. So we drain it first, and then we have a single port. And then after a couple of days, we follow the patient. After 4 weeks, we saw the patient is not improving. So we decided to insert another port with a metallic stent, and we go inside, do active necrosectomy with hydrogen peroxide, and then frequently we use different tool, use a snare, sometimes use the Ratnet, and so you have different way to clean those necrosis. So this patient was managed with the double or dual metallic stent drainage. So sometimes in those difficult cases, you need to have at least multiple gate or multi-gated or maybe dual therapy, endoscopic or percutaneous. So now we think once you drain the patient, then you have to think how to follow your patients. So one of the things you have to follow your patient, the diet is very important. So nasogeneal feeding is one of the study from India shows there's a good relief of pain of those patients, more than 80% of those patients that give relief in the 1 or 4 days of the world of necrosis. So we have to consider to give the patient enteral nutrition and mainly using the nasogeneal feeding. This have to discontinue most of the patients, they use BPI. So we have to stop using BPI in those patients because you have maybe the risk of infections are higher. And then as etiology, smoking and ethanol should be quit. And also we have to follow the patient clinically with the imaging, and we prefer usually CT scan or MRI to follow our patient. This is one of the algorithm, as you see. So this is what was published this year by Todd Barron. Clearly stated that if you have a symptomatic infected cyst or ward of necrosis, you have to think about to assess by EWAS. If you have a clear, you cannot drain these patients and you don't have any clear access, then you have to think about percutaneous drainage. If not, then you have to use EWAS, and they prefer LAMS for drainage. If not improved, they have to consider, or maybe the collections already extended the paracolonic extension, so you have to consider combined with the aggressive percutaneous drainage. Then you have to follow your patients. If they have large amount of solid component, you have to follow those patients by clinically. If they are improved without active necrosectomy, then you are thinking about planning to remove the LAMS, or if still there's a necrosis, so you have to do direct necrosectomy with a frequent necrosectomy to let the patient improve and resolve. As you see here, symptomatic ward of necrosis, use or think about use drainage, prefer LAMS, and then follow the patient clinically after 72 hours. And if you have a combined with irrigation or hydrogen peroxide, and then you repeat necrosectomy based on the clinical needs, or maybe consider other way as percutaneous or video assist retroperitoneal drainage with the surgical colleagues. Some of the questions since not answers or difficult to answer. How many plastic stents you have to insert? Do you prefer to use a lamp with the 15 or 20 millimeter? And then did you consider the dual axis or multi-gated in the same first time, or you have to follow the patient clinical, consider them this later on? And then how many necrosectomy you have to do, it depends on the clinical scenarios, to do or to use hydrogen peroxide to facilitate dissolving the thick necrosis, and also some of the antibiotics, both procedure indicated or not indicated, despite you drainage the patient. These one of the things sometimes difficult to answer, but it's based on the clinical practice. So I will end my talk by these messages. Usually we have to consider multidisciplinary or multi-specialty team based on management. So you have to consider surgical, radiology, ICU, gastroenterology, and then you have to think about decided to have other medical treatment for this patient. You have to use our Atlanta classification, our clinical practice, to differentiate between the pseudocyst and ward of necrosis. Prefer to do MRI or secretin MRCP as a pre-procedure imaging to help us for other etiology. And also still we are sticking to the standards of more than 4 weeks to let the ward of necrosis to be formed, and then to have a good mature wall. But sometimes in rare cases, very sick patient, infected collections, multiple organ failure, you have to consider early drainage. And then you have to use a sip-up approach, which is endoscopic. LAMS, difficult access, sometimes you have to use LAMS either hot or non-hot. And also the sip-up, if you need to do necrosectomy, no need to do necrosectomy from the first drainage. You have to think about necrosectomy if the patient is not improved. I think I have to conclude, and thank you for letting me present this topic.
Thank you very much, Dr. Lehebi, for excellent presentation, and also for very stick of the time. You just finished in your time, and this is a very, very good, which is one of the future of the leaders, the star that he can he present all. You see the timer. You can listen to the timer. I make a timer for you, and the timer it is now good. So you are very stick. So thank you for that. And now any questions from the audience or the panelists to Dr.
I have one question,
yes.
dear Professor. My question is about the location and the size of the collection. Sometimes we face cases of collection at the neck of pancreas, not at the tail. Does it matter regarding the modality for treatment or not? Also the size of the collection.
Yes, I think this is one of the things you have to consider. As I told you before, you have to do EUS, and then if it's difficult to drain, then you think about percutaneous. As I agree with you, some of the locations very difficult to drain. One of them, if it's high in the fundus, so it's difficult to drain. If it's almost close to the G junction, I have one patient almost in the cyst, it's almost in the chest, you cannot drain it. So away from G junction, not in the fundus. And then if the duodenum, usually if it's stick to the bulb, you probably sometimes it's easy, but if it's in D2, usually this is one of the difficult procedure. The best, usually, if you have it in the body and the antrum, it will be very easy. But I agree with you. You have to have more evaluation by EUS. EUS is better than MRCP and MRI and CT scan to evaluate the locations of your puncture.
Any other comment or question? So it is very clear to all the audience, all the panelists. It's a very nice presentation, very short in time, and also in the subject itself. And this is one of the future of the presenter, how to present everything in time. Khaled, you are ready?
Thank you, Professor.
Ready?
Aywa.
Ready?
Yes, Khaled, ready.
Yes, how? You can start, Khaled.
Can you hear me?
Yes.
Yes, you can start. We listen to you.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like first of all to thank Professor Hussein Al-Amin for the invitation, and thank you, Professor Ibrahim, for this introduction. So my task today is endoscopic treatment of benign refractory esophageal strictures. I'm going to speak mainly on refractory esophageal stricture, which is one of the really very important and very difficult to be managed. These are my objectives. Refractory stricture definition, etiology, technique of the standard treatment, which is the dilatations, and then we will go for the advanced incisions, injection with steroid or mitomycin, then a stent, and if we fail, what to do for our patients. So this is one of our patients who presented with corrosive injury, and after 6 weeks, he came with severe strictures, and after 5 or 6 dilatation again. Whenever we go, I went for this patient to 17 millimeter again, and whenever we go, we are seeing the same stricture. So this is one of the really very difficult especially with corrosive injury. The etiology of the esophageal stricture are many, and the most important, the refractory, you can see it in the peptic strictures, eosinophilic esophagitis, sometimes if it is chronic, caustic injury, radiations, and post-esophagectomy, which is really sometimes very, very challenging. Classification of strictures, very important to know the classification of your patients. The dysphagia scoring system, it will tell you how bad is the strictures, benign versus malignant stricture, very important, especially if you are seeing the patients from other referral, malignant, until proven otherwise. Then once you sure that it is not malignant, then you will go for the dilatation. And if it is benign, is it simple or complex? The stricture severity, you can assess by endoscopy directly, and of course the definition of the refractory. The dysphagia scoring system is very important. Say, for example, if you have a patient who is unable to swallow liquid, so this is a really difficult case like our patients. The stricture severity also, you can assess it easily by the endoscopy. If the scope busts without resistance, this is mild. If the scope busts with resistance, this is moderate. And if you cannot bust the scope, this is a severe stricture. Simple stricture, a short, symmetrical, straight focal. Usually you can see it in Chasky ring and esophageal web. Most of those cases.
Dr. Khaled, what the scope? What the diameter equal? You said your scope can bust. Yes, this one, yes.
10 millimeter.
You should say that.
Our scope is usually 9 or 10. So
but,
once
but because this classification, you should put the 9 or 10.
This is a rough idea to tell you about the stricture. So if your scope is passing, this means that it is mild. If it is resistant while you are passing, this is moderate. And if you cannot pass, so this is
normal scope, normal 10.
Yes, normal scope, yeah, normal scope.
Thank you.
So simple stricture, as we said, most of the time, 1 or 3 dilatation, those cases, they will be done. But sometimes you, in 25%, you need to go up to 5 sessions, and resolution of those simple stricture usually 95%. Now, complex stricture usually iatrogenic, anastomotic, caustic, like our patient radiations, usually more than 2 centimeter, angulated, severe, narrowed strictures, asymmetrical, irregular, tortuous, more likely to be recurrent and refractory, and usually difficult to manage. The definition of benign refractory esophageal stricture, inability to dilate to 14 millimeter over 5 sessions at 2 weeks interval, and the recurrent benign esophageal stricture, the definition is inability to maintain a satisfactory lumen diameter for 4 weeks once the target diameter 14 millimeter has been achieved. So what's the aim of endoscopic management is to relieve the symptoms of dysphagia. So if you have a patient without any dysphagia, whatever you are seeing, no need to be dilated. So dilatation is mainly for patients who have dysphagia. So this is the patient. You can see very tight strictures. For this patient, sometimes I use the direct catheter of the ERCP. You can see, you can put it, you can put injection, you can put the contrast, and then you can put your guide wire easily. This is one of the things that it can help you during the dilatations. So this is the bougie. You can see, always try to use the X-ray, and you can see that this is the contrast which we injected, and you can see the marker is going down to the stomach. One of the important things with the bougie is don't use it when you have contracted a small stomach, because of the distal tip that it can injure the stomach. So this is post dilatation. You can see very nice dilatation, and you can see there is a good tear, and the scope is passing, and you can see here this is the nice tear, and but the patient didn't also improve. We went again for the other modality. So the esophageal dilatation general tips, both whether it's balloon or bougie are equivalent. They have equivalent outcomes. Both have equivalent safety. The complication of perforation 0.1 to 1.1%. The success rate is 70 to 90%. But the problem with the balloon are more expensive than the bougie. Savary or wire-guided dilatation, always use it for complex stricture. Fluoroscopy is not mandatory, but when you have complex stricture or difficult, you need to use the fluoroscopy. Not wrong to dilate until the tear occurs. So very important. Once you have a good tear, this means that you have a good dilatations. Ultrasonic or pediatric scope is very helpful if you have it in your unit, or you can use the catheter to delineate your guide wires. Important questions when you are dilating, when to start the dilatation, of course, after healing of the inflammation of the ulceration, because once you are dilating with the ulcer, the perforation risk is high. At what frequency do we dilate? Every 1 to 3 weeks. What are the dilator of choice, bougie or balloon? Both of them, they are equal, but sometimes some people, they prefer this or that, but if you will come to the evidence, both of them, they are equal. What is the target diameter? 13 versus 15 or 16 versus 18. So usually, if you have a refractory and a recurrent, usually 16 is better. Start within 1 to 2 millimeter larger than the estimated lumen. Of course, we follow rule of 3 and rule of 2 for eosinophilic esophagitis because of the risk of the perforations. The X-ray is very important. If you have it in your unit, you can see that the disappearance of the waste, and you can see your situation in an elegant way. This is again another patient who came to visit Dubai. You can see that he had impaction of food, and we tried to dilate him several times. And this is, I think, the third or fourth time. And he used to drink mainly fluid and soft diet. So once we dilated once, he used to come again for the, you can see the esophagus, his esophagus is tube-like, and his age is 74, so he used to come again for the dilatation. So this is, I think, the third or fourth dilatations. You can see this is, this case I used the balloon, and then after that you can see, after the dilatation, he had multiple level of stricture. All of them, we dilated them from the upper, mid, and lower esophagus. You can see here, I'm trying to induce a scope. So this is the proximal one. And then if you will go down there deep, you can see the other tier here. You can see them, and the patient did fine. So the endoscopic dilatation of benign esophageal anastomotic strictures over 16 millimeter has a longer lasting effect. And if you will see the period, overall dilatation free period, you can see it with 18 millimeter is longer and better. And maybe some people, they are afraid about the perforation, but if you will see the 18 has only 1 perforation versus 7 in the 16. This is again, another study came this year, comparing 13 to 15 versus 16 to 18. And from this, because of the dilatation up to 16 to 18, diameter was associated with fewer endoscopic dilatation sessions during the follow-up. So they suggest to go 16 to 18 in the refractory cases. Steroid injections, triamcinolone, 10 to 40 milligram, for those who are not responding to dilatations. So that's this patient. We went again with injection of the steroid. You can see we injected in 4 quadrants and many levels. The intralesion steroid benefit of in benign refractory esophageal stricture. This is a meta-analysis comparing the placebo versus the steroid. You can see that the period dilatation index was better with the steroid. And this is the conclusion of this meta-analysis. Intralesional steroid injection increased the time between the endoscopic dilatation of benign refractory esophageal strictures. Mitomycin C for refractive benign esophageal strictures. It is derived from the streptomyces. It is anti-neoplastic and anti-proliferative. The technique is to apply it either with cotton blades or spray or injection, and you need to keep it for at least 1 to 5, and the mean is 2 minutes. So mitomycin, the results are really encouraging, better than the steroid. 24 studies, 145 patients. The mean follow-up 23 months, because most of the cases are caustic injury. You can see that 59% clinical response and 21 partial response. So it looks that mitomycin C, if it is available, is better than the steroids. Now, the other modality, if you failed, you can use the endoscopic incision therapy. This is a study comparing the incisions versus the bougie, and both of them showed the same, bougie versus the incisions, which is they are equal in terms of the number of dilatations, success rate, and the time interval between dilatations. So if you have a patient who failed with the injections of all these things, what will be the next? The next will be a stent for refractory of benign esophageal stricture, usually only for refractory treatment. When you fail with dilatation and injection of steroids, you need to keep it at least 3 months. And the problem of these stents are the migrations. Overall effectiveness is unfortunately not more than 40%. The clinical outcome following a stent placement in refractory benign esophageal stricture, this is a systemic review and meta-analysis of 444 patients. They used, in this study, the meta-analysis, they reviewed all the stents, the fully covered plastic and the biodegradable stents. And you can see this result of this board clinical success is 40%, better with fully covered rather than biodegradable stents. and overall migration rate is 28, and less with the biodegradable stents. Now, one of the very important, with fully covered, is the migration rates. You can reduce the migration rates by many ways. One of the things is not to bridge the stent below the GE junctions. The other thing is you can use the over-the-scope clip or the suturing, but the through-the-scope clips usually will not hold the stent, and the stent will fall down. Some people try to use the lamps for those strictures, especially when they are short. The results are encouraging with a success rate of around 80%, but the migration rates improved to 80%. But the problem is that these stents with the big outer phalanx can cause fistula, and there are case reports of tracheoesophageal fistula, so you need to keep your mind. And I think these stents need to be modified, especially the outer phalanx, if you need to use them, the companies, for this purpose. So the ESG guidelines in 2016, they recommend against self-expanding methods as the first line for benign esophageal strictures. Consider temporary stents for refractory, and they don't specify a certain stent better than the other, but the recommendation is not to use partially covered stent because of the risk of removal after 3 months, and it will be a nightmare to remove those stents. So what will be the treatment if you fail? You have two other options: self-dilatation or surgical treatment. Self-dilatation therapy, old, but old is gold. This is a study, 17 patients. You can see the success rate is around 94%, and the ESG recommend to use it if you are failed. So this is the treatment algorithm for patient with benign esophageal strictures. If you have a patient with you dilated him with either bougie or balloon, more than 16 millimeter for 3 to 5 sessions, and you fail, then you are in the period of refractory. You can use dilatation with combined with injection of steroid or mitomycin C, or you can use incisional therapy. Then if you fail, you can go for stent placements. If you fail, you can go for self-dilatation or surgery. So to conclude my talk, refractory benign esophageal strictures remain a commonly encountered problem. Patients may need multimodality treatments. Patients may fail despite maximally aggressive efforts, and consider long-term stent for chronic treatment. Like our patients, finally, he responded well with the fully covered stents. And surgery is the last option, although most of the surgeons are often unenthusiastic to go to take those patients, especially if the stricture is post esophagectomy. Thank you.
Thank you, Khaled. You just finished on time also. Very good. I think I think you have dealing with it look like a simple subject, but it's you can give this, which is everyone see cases like that every day, but you give us an alternative. It's a very, very subject, and all the experts, when you said to them a case of ERCP or a case of benign stricture, you said an ERCP. Many of the professors, many of the experts, they don't like deal with the benign stricture because for me it's very difficult. And now there are, as Khaled said, there are many options for that, and he will give many examples how to manage. So thank you, Khaled, for this very nice practical, very practical lectures on benign stricture, and waiting for any questions.
دكتور بسأل سؤال أشرف أبو بكر مع حضرتك.
دكتور أشرف وحد يقدر يقول لك لا يا ابني. حد يقول لك لا دكتور أشرف. اتفضل يا بيه. دكتور أشرف رئيس قسم الجهاز الهضمي بمستشفى المعادي ومن الناس البايونير في الاندوسكوبي الحقيقة. اتفضل يا دكتور أشرف.
شكرا دكتور خالد على المحاضرة الجميلة دي. I would like to ask about the frequency of repeating the session. You mentioned that you have to do sessions for more than 3 or to 5 times. If we finish the dilatation by the three sizes, three measures of for the bougie, for example, and the patient is asymptomatic, should we repeat the dilatation, or according to the symptoms, waiting for if you come symptomatic again, we do another dilatation?
Excellent question. I think the best monitor for this is the patient. So if the patient is asymptomatic and enjoying taking solid food, I think I wouldn't dilate unless he is symptomatic. So this is really very important. I wouldn't dilate a patient who is really, even if you dilated 15 millimeter and he is fine, I think we will not dilate unless he is symptomatic. Again.
Any other comment or question?
دكتور ابراهيم بعد اذن حضرتك I have a question. حسام غنيم.
طبعا اتفضل.
دكتور خالد thank you for
صورتك يا حسام، صورتك يا حسام، انت صورتك قاعد في مكان جميل جدا، فين صورتك؟ ايوه كده.
Okay. Dr. Khalid, I think for the higher up esophageal strictures, just below the upper sphincter, we not usually tend to reach the 15 millimeter with dilator. What do you think?
Well, if it is refractory, sometimes you need to go to 15 and even above 15. If you will see if you review the literature, the risk of perforation is less, as I show you in 18, 17 versus 16 or 15.
My question is, does this apply to the very high up esophageal strictures as well?
You can dilate up to 15, 16, 17, there's no issue. As far as the patient is still symptomatic.
Okay, thank you.
Any other comments? So thank you, Khalid, for your lectures. We hope to see all of you face to face in the future. And I let Professor Muhammad
Thank you, Professor.
Sorry, Muhammad Tajuddin. He can present another two excellent speakers. تفضل يا دكتور محمد.
بسم الله الرحمن الرحيم. شكرا جزيلا دكتور ابراهيم استاذنا الفاضل على مشاركه حضرتك في السيشن دي، وشكرا استاذنا الدكتور حسين على العطاء والنجاح المتواصل يا رب العالمين. يسعدني جدا اشرف استاذنا الفاضل الدكتور حسام غنيم في موضوع يعني يمكن very important topic.
دكتور علي فرج الاول.
الدكتور علي استاذنا الفاضل الدكتور علي في موضوع يمكن برضو very important عن الالترا ساوند ايفالويشن للعيان ويز انفلاماتوري باول ديزيز. اتفضل استاذنا الفاضل.
دكتور محمد شكرا. دكتور ابراهيم مصطفى وحشتنا.
وانت والله.
شكرا دكتور حسين الامين على يعني الاستضافه الكريمه، ونتمنى لكم كلكم كل الامان الطيبه والصحه. يا ترى عند حضرتك الصوره كويسه؟
هي احلى من اللازم يعني. ما شاء الله.
جميله ما شاء الله.
ما شاء الله.
انا النهارده
والله العظيم ولا ترامب يعني.
الله يخليك يا باشا.
حضرتك منور يا دكتور علي والله، ربنا يبارك فيك دايما.
انا التاسك بتاعي النهارده سهل جدا. is to convince you to use the ultrasonography in patients with IBD. احنا طبعا متعودين نستخدم الالترا ساوند in seeing the liver, the spleen, the kidneys and so on. انها في الحقيقه في فايده اكبر من كده بكتير قوي. Examination of patients with IBD. So my task is to convince you to use the ultrasound in diagnosis and follow-up of patients with IBD. And as you all know that we have ultrasound already in the clinics and we have it in the hospitals, why not using it? Ultrasound is really a very good technique. It's safe, practical, cheap. It's very reproducible. You can do it several times a day, every day, no problem at all. We can use it either in suspecting patients with IBD, would like to confirm it, or you already have a patient with IBD and you would like to follow him up. Just to remind you that the only real-time examination is ultrasonography. بمعنى, it's the only way to see a moving bowel. It's the only way to see how the pressure reacts with this moving bowel. It's the only way to see that if the bowel is compressible or not. Nothing can give you this idea. I'll give you an example of a patient. He's a 42-year-old woman who presented with abdominal pain of 2 years duration. This patient had very umbilical pain, colicky, mostly postprandial, sometimes very severe. She has occasional vomiting. Recently, she had painless swelling of the lower limbs as well as the skin and of the abdomen, edema of the skin of the abdomen. She had colonoscopy to the cecum. Unfortunately, the operator did not have the ability to go to the small bowel because of narrowing of the ileocecal valve. Examination showed an underbuilt female, normal vital signs, pitting edema, no palpable organomegaly or masses, and no specific areas of tenderness in the abdomen. Before I talk about what we have seen in this patient in the ultrasound, I'll show you the normal ultrasound of the bowel. The ultrasound of the bowel, it looks like sandwich. You have 2 layers which look black or gray and 3 white areas. The 3 white areas are the interface between the lumen and the mucosa, then the muscularis mucosa, then the submucosa, then the muscularis proper, and then the peritoneum. I'll show an ultrasound in a normal patient, then we'll go to our patient to see what's going on. We start examination in the right iliac fossa. We'll go laterally until we see the iliac vessels, the vein and the artery. And just by moving a little your probe, you will find the terminal ileum moving here. That's the normal terminal ileum. This one, the moving structure here, going around the vessels, is the normal ileum. And this is the iliopsoas muscle. It's very easy anatomy. If we go to our patient, we find this. That's the cecum full of feces. Then when we go laterally, you find all the changes that can occur in inflammation. The first thing which causes inflammation is thickening of the bowel. Because of the edema, because of the inflammatory cells, you will see that the bowel is markedly thickened. The bowel wall is markedly thickened, as you can see here. Not only this, the 5 layers we have seen before are gone. We have loss of the stratification. When you look at the lumen is narrowed. When you look at the bowel, it's not moving anymore. When you press with your probe, it is not compressible. Even more, when you go more laterally, you will see that this narrowed area, the one we see here, is preceded by, as you will see in a minute, you can even measure this structure. You can see a markedly dilated bowel just proximal to the thickened areas. That's the markedly dilated bowel. So this is a very significant stricture. If you would like to know that if this bowel change is inflammatory or is it fibrotic, just press on a button of the Bowel Doppler and we'll show you. If you have a lot of red color here, this means that high vascularity, this is inflammatory area. So we can use this ultrasound in patients with IBD, especially Crohn's disease. The changes we are looking for are either bowel thickening, alteration in the bowel, in the wall equipattern, as I said before, loss of stratification, hyperemia, loss of elasticity and peristalsis, as the last patient, creeping fat. This is something very interesting. When you have inflammation in Crohn's disease, the fat increases around the inflamed part. And this is a good thing, because by separating the other bowel parts, you can see the inflamed part very easily. Sometimes you can see some lymph nodes. You can see also complications. You can see very clearly stenotic area, like the one we have seen before, fistulae, inflammatory masses, or abscesses. You can use it either in early evaluation of suspected case, and you can use it to see the extent of the Crohn's disease, the areas you cannot reach with the endoscope. You can differentiate between chronic inflammatory colitis and Crohn's disease. You can diagnose complications like stenosis, obstruction, fistulae, abscesses, and perforation and toxic megacolon as well. In ulcerative colitis, we can use it, but we are using it less frequently because it's only an inflammation of the mucosa and the very superficial part of the mucosa. And as you know, some of these patients have the inflammation only in the rectum, where you cannot reach with the ultrasound through the abdomen. But anyway, you can look at this: bowel wall thickening, alteration in the bowel wall, echo pattern, hyperemia, and loss of obstructions. I leave the ulcerative colitis for another presentation. So we have also new techniques. We can examine transperineal to examine the lower part of the bowel, the rectum and the anal canal. We can do elastography to see the elasticity of the bowel. We can use contrast to inject intravenous and then to see the changes of the bowel with this contrast as if you are doing angiography, but with ultrasound. So the take-home message is that ultrasound is really a great tool in diagnosis of IBD. It's practical, safe, cheap, and reproducible. Having said that, I have to say that it is not specific. So you have to put it in addition to the other things you are seeing in your patient. So simply, I would like you to do this. Next time you suspect an IBD, use your ultrasound. Next time you follow up your patients with IBD, especially children, use your ultrasound. Learning ultrasound of the bowel takes only 2 weeks. Only 2 weeks. It's not that difficult job. Thank you.
شكرا جزيلا يا فندم على المحاضرة القيمة المركزة جدا جدا جدا. ولو في أي أسئلة من الأودينس يا ريت يتفضلوا.
دكتور علي، أنا حسين الأمين.
أهلا حسين.
ازي حضرتك يا فندم؟ منورنا والله، منورنا وتشرفنا
على المؤتمر.
الله يكرمك، منورنا وتشرفنا، ربنا يكرمك.
سهرتنا يا عم.
رول اوف التراساوند طبعا يعني فيري امبورتنت ناو، ويمكن احنا برضو حضرتك اشرت ليه ان ممكن في الدايجنوز كمان بنستخدم الدوبلر in addition to the ultrasound. طبعا دي حاجه من الحاجات المهمه جدا not only for diagnosis but also for follow up of patient on treatment. دي الجزء الثاني برضو addition of elastography very important to differentiate between fibrotic and inflammatory structure. انا بس عاوز اعرف sensitivity بتاعت الالتراساوند corresponding to my MRI or CT in delineation of fibrotic versus inflammatory structure.
ما تقدرش تعتمد على الالتراساوند قوي الا اذا استخدمت كونتراست. اذا ما استخدمتش كونتراست مش هيبقى قوي جدا. يقدر يوريك الاكستريمز اذا كان دي فيه فاسكولاريتي ولا لا. انما if you'd like to know for sure if this is a fibrotic structure or this is inflammatory structure، يا اما عندك الام ار اي يا اما عندك كونتراست انهانسد التراسونوجرافي.
شكرا جزيلا. شكرا.
عفوا.
شكرا يا فندم. هل في اي اسئله ثانيه؟ شكرا دكتور علي. يشرفني برضو اكمل تقديم استاذنا الفاضل دكتور حسام في موضوع يمكن من المواضيع السهل الممتنع يعني، وهو الكولونيك بوليب regarding detection او characterization of polyps. اتفضل دكتور حسام، بالتوفيق ان شاء الله.
شكرا دكتور محمد، شكرا دكتور ابراهيم، شكرا دكتور حسين اللي اداني الفرصه ان اكون موجود مع حضراتكم النهارده ودعاني هذه الدعوه الكريمه. My talk today colonic polyposis. صعب جدا ان انا اتكلم على colonic polyps كلها بكل تفاصيلها in 15 minutes، لكن عشان كده انا I try يعني حددت approach in my talk that I will give an overview about colonic polyps, and I will not go into much details of everything, but perhaps a little bit of everything, like الطبق الأوردوفر قبل ما ندخل على ال details of colonic polyps لو كل واحد عايز يدخل في certain details. Anyways, So my objective today is talking about the overview of colonic polyps, mainly to our young GI endoscopists. What are polyps and their classifications, how to detect polyps, and how to characterize polyps. First of all, let us do this exercise together before we start my talk. Look at this picture. This is a polyp, and tell me, or tell yourself, ask yourself, what are you looking for in this picture? How are you looking at it? And what is this at the end? And then we will do the same exercise after we finish the talk and see if there is any difference. So colonic polyps, the term polyp refers to any circumscribed mucosal growth, either flat, depressed, sessile, or pedunculated, that is visible through an endoscope, a magnifying glass, or a stereo type. Colonic polyposis classifications, we have three classifications. We have classifications from the pathology, the pathological classification, which classifies polyps into neoplastic, non-neoplastic, or polyp-like lesions. And then we have an endoscopic or a morphological classification, depending on the appearance of the polyps. And this is, we're talking mainly about Paris classification. And then we have endoscopic pathological classification using image enhanced endoscopy, which is a sort of in vivo pathology, trying to make sense of, trying to make pathological or histopathological sense of what we are seeing through the endoscope. And we have quite a few classifications for that, vascular ones like the intrapapillary capillary loop pattern, or fine mucosal structures like the Kudus classification, the NICE classification, and the basic classification. So start quickly by the pathological classification, and this is only an overview. Pathology classifies polyps into neoplastic, non-neoplastic, or polyp-like lesions. Neoplastic being adenomatous, carcinomas, lymphomatous polyps, or submucosal tumors, the GISTs, gastrointestinal stromal tumors. The non-neoplastic ones are not tumorous polyps. So it's not a matter of being benign or malignant in the neoplastic, but those are non-tumorous polyps, like the hyperplastic polyp, which is a sort of a regenerative metaplastic polyp, hamartomas, malformation, inflammatory polyps, or inflammatory fibroid polyps arising from the connective tissue overgrowth. And one of the polyposis syndromes, which is the Cronkite-Canada polyposis syndrome, and it presents with lymphoid hyperplasia, and of course, schistosomal polyps. Whereas polyp-like lesions which may look like polyps, but they are not, like the dysplasia-associated lesions or masses with the ulcerative colitis, and to less extent with Crohn's, antibiotic-associated colitis, foreign bodies, condyloma cognatum, and pneumatosis cystoides intestinalis. The neoplastic polyps, the adenomatous polyps, histopathological classification, this is very important. It's tubulous, villous, or tubulivillous, or serrated, because it's very important to know how much the villous component of the polyp, because this is the dangerous part of the polyp. And of course, for adenomas, we have the endoscopic classifications, and as we're going to see in a while, and some clinical pathological classifications arising from the adenomatous polyps, which most important of which is the familial adenomatous polyposis, the Gardner, Turkowitz, and attenuated FAP, which is a variant of familial adenomatous polyposis, and other syndromes like the hereditary flat adenomas, Muir-Torrey syndrome, hereditary mixed polyposis syndrome. And of course, the carcinomas, most important of which is the hereditary non-polyposis colon cancer, which is not an adenoma turning into cancer. So there is no adenoma carcinoma sequence. This is a de novo cancer, lymphomatous polyposis, and the GISTs. And here we can see some of the examples of typically exophytic adenomas with pedicle, different size pedicles. And of course, we have the non-exophytic flat adenomas. And the main important feature about them is that they tend to have high grades of dysplasia, and they occur more frequently. And they are called laterally spreading tumors or creeping tumors. And we have here some examples of typical small sessile adenomas of the colon and rectum, and a moderate sized sessile adenoma. And we can see next to it a small hyperplastic polyp and a larger sessile villus adenoma. And of course, the flat adenomas, which can become more apparent with the help of some image enhancement. Namely, here is the chromoendoscopy. And of course, we can get mixed types of polyps. Here we suspect a polyp due to decreased vascular pattern, and indigo carmine helps to delineate the polyp. And again, we can see the small hyperplastic polyp near the flat one. I will not go into much details, as I said, but I still had the slides all ready for young colonoscopists or endoscopists for their review. So serrated adenoma is a very important feature, and for which some techniques were specially developed, like the blue light imaging and the basic classification, which was especially tailored and made to detect serrated adenomas and differentiate them from hyperplastic ones. Serrated adenomas most of the time can appear, can be missed. They're very small and can be overlooked. Familial adenomatous polyposis, again, I will not go through the details of those polyposis syndromes, but it's good to know the pathological classification. Familial polyposis also can be present with very small, very minute polyps, and they can be seen with image-enhanced techniques like chromoendoscopy, and also can present with non-exophytic polyps. The hereditary non-pulposa colorectal cancer, or the Lynch syndrome, is not that common. It accounts for at least about 5% of colorectal cancers, but it's very important because it's the disease of the young age, and it has a predominance to the right side of the colon. And this is a typical laterally spreading tumor, and again, can be small or start small and can be overlooked during colonoscopy. The submucosal tumors or the gastrointestinal stromal tumors can also be overlooked, and they have typical endoscopic features, the most important of which, of course, is a normal overlying mucosa or intact mucosa overlying a broad-based elevation, whatever it is. It can be very soft, like in lipomas. It can have special colors, like a yellowish color in carcinoids, etc. And this is a typical, what we call cushion sign of a very soft lesion, in this case, a lipoma of the colon. And this is a picture of a carcinoid. It's not very typical. I'm sorry about the quality of this picture. Lymphomatous polyps are rare, are very rare. And they usually have a typical appearance, a distinct form of colorectal lymphomas with multiple large nodules and central depression. So this is the endoscopic giveaway how to suspect or diagnose a lymphomatous polyp. It has a central depression in the middle of the polyp. Non-neoplastic polyps, talking about hyperplastic, hamartomatous, and inflammatory polyps. Hyperplastic polyps are usually very small, minute, and they have pale surface. So this is the endoscopic giveaway pathognomonic picture of a hyperplastic polyp. They have almost zero malignant potential, so you don't need to do anything for hyperplastic polyp. And this is how they typically appear during colonoscopy. They can also be flat, and this is a very subtle polyp that needed some image enhancement. Juvenile polyposis They are a sort of a hamartomatous type of polyps, and they are usually multiple, and in the colon and rectum resemble exophytic adenomas. But they have a typical appearance, as we see, typical endoscopic appearance that you cannot really miss. And this is another of the appearance of juvenile polyps. Inflammatory polyps, they are finger-like projections. And this is the most common appearance of inflammatory polyps, that they are finger-like projections. They can present in a multiple pyriform type, and they can be bridging, inflammatory polyps with mucosal bridging, or they can surround a diverticulum, and those are very dangerous polyps that you should not attempt to remove easily or difficultly, because this is, at the end of the day, it's an inflammatory polyp that you need to do nothing about, really. The polyp-like lesions, like the dysplasia-associated lesions or MAST, the antibiotic-associated colitis, even you can mistake a foreign body for polyp, condyloma accunatum, and the pneumatosis cystoides intestinalis, which is because of a gas-forming bacteria leaking into the mucosa through mucosal breaks, and it can be quite fatal in children. So this is a typical picture of a condyloma accunatum and melanosis coli. We see the brownish pigmentation and the multiple lymph follicles appearing as white round spots, contrast to the dark background mucosa. And this is the whitish plaques that can be mistaken for polyps, but those are antibiotic-associated plaques of colitis. And now we come to the endoscopic morphologic classification, namely the Paris classification. And this is very important to know. And I urge every endoscopist doing colonoscopy to report the polyp in terms of their classic Paris classification. And the endoscopic pathological classifications using imaged enhanced endoscopy. And the aim here is reaching an in vivo pathology. Image enhanced endoscopy, we can have image enhancement prior to the processor, that is the high definition endoscopy, magnification, chromoendoscopy, NBI, eye scan, blue light, or linked color imaging, confocal laser, or endocytoscopy, or post the processor. After we get the image, we work on the image analysis, spectroscopy, optical coherence tomography, or autofluorescence imaging. Why image enhancement? Well, it's for early detection of GI malignancies in Barrett's, in gastritis to cancer sequence, and adenomas to carcinoma sequences. And of course, overcoming the challenges like overlooking polyps and characterizing what we see and removing the lesions in full. We have different methods for image enhanced endoscopy. We have techniques for differentiation, that is detection, finding the polyp. And we have other techniques that is for characterization. When we find the polyp, what does this polyp mean? Is it adenomatous? Is it benign? Is it malignant? So this is characterization. As we see here, this is not just a bunch of flowers. We can see some faces only if we are looking for faces. So this is how to find polyps in a colonoscopy. You have to be looking for them. And we have many image enhancement techniques that I will not go through in details, but the techniques for detecting lesions, that is differentiation, are the autoimmune fluorescence, the linked color imaging, and this has been quite properly validated. Chromoendoscopy, of course, which is the most simple and cheapest, and also very effective. And lastly, how to characterize the polyp once we see it. We have to know what this polyp is. We have to know that this is the the ugly part of the polyp here in characterization. This is the tubulovillous adenoma, and this is an area of intraepithelial carcinoma. As you can better see here with narrowband imaging. The vascular pattern is also very important, perhaps not in the polyps, but in the Barrett esophagus. Fine mucosal pattern classification, the earliest was the Kudus classification. And this gave us a lot of sense. We can make sense of what we see in terms of the polyps, the types of polyp, whether it's a hyperplastic polyp or adenomatous tubulus villus or tubulovillous adenoma or complete intraepithelial neoplasia. This is how the images of NBI appear without magnification, and of course, much more obvious NBI with magnification. And this has been validated with pathology results, and of course, developed especially for the narrowband imaging technique, is the NBI International Colorectal Endoscopic Classification, the NICE classification, which was missing a little bit on the serrated polyps. It was not very clear, the classification of serrated polyps in the NICE classification, and therefore the blue light imaging by Fuji developed another classification called the basic classification, which covers very well the area of serrated adenomas. Again, more techniques that we can use for in vivo pathology, like the confocal laser endoscopy and the endocytoscopy, which enables visualization of different cytological and architectural features, including the size and arrangement and density of the cells. So which polyps become malignant and determination of malignant transformation? Of course, the polyp size is very important. The amount of villus component, كل ما زاد الvillus component, كل ما زاد فرص malignant transformation, and the grading of dysplasia, the polyposis syndromes, round figure, we're talking about 5% of adenomas that can turn into carcinomas. And the impact of treatment, of course, is huge. After properly detecting and characterizing lesions, I can assess if I'm fit to remove this polyp or not, because not every endoscopist should remove every polyp. And this depends very much on the degree of experience and the level of comfort of that endoscopist. So to finish, I would like just to show you the breakdown of colorectal polyps, approximately their incidence and their malignant risk. The tubular adenomas, they're probably the most type of adenomas that we see, 45% incidence, but the malignant transformation risk is 2%, whereas the tubulovillus is 6% incidence and malignant transformation 20 to 25%. And the villus, of course, carries the highest percentage of carcinoma. And this is colorectal cancer pre-cancerous lesions. This is, of course, a quiz that you can do easily now, because this is not a polyp, this is a seed. And again, as we started, if you're looking at the same polyp, now, after our talk, what are you looking for? How are you looking? And what is this? I think if you can find some differences between your analysis for this, the same image before the talk and your analysis after the talk, this is exactly what I meant to give in my lecture, in my talk. And my take-home message is you have to find the polyps that detect, characterize the polyps in vivo pathology, identify syndromes, and that is the classification, and then decide on the treatment, which polyps to remove, which endoscopist, how to remove, and when to refer to surgery. Thank you very much.
شكرا دكتور حسام على المحاضرة القيمة، يمكن اللي جمعت كل ال types of polyps و how to detect and how to characterize. بشكر حضرتك جدا على المحاضرة القيمة، ولو في أي أسئلة من الأودينس اتفضلوا.
دكتور حسام، ممكن أسألك سؤال؟ أنا شريف مجاور.
دكتور شريف، أهلا بحضرتك، اتفضل.
Thank you so much, as usual. Very elegant and very clear talk. And really demonstrated all about polyps. You started saying that you will just give us an overview, but really it was a talk which involved a lot of information and a lot of knowledge. Thank you for that. But I would like to tell you that we are in an era in the coming few years, we are going into the artificial intelligence, which will really make things very easy, not only in increasing and improving the yield of polyps, but even in characterization of polyps, the pathology, and a lot of details can be easily known through the artificial intelligence. In spite of this, I urge all endoscopists still to learn the skills you're working and you're trying to tell them that it's important. But we have to know that in the coming few years, things will dramatically change once the artificial intelligence goes into depth with the more advances we are going to see. So again, thank you.
I agree very much, Dr. Sharif, and this is an update that was worthy of adding to this talk. Thank you for saying and mentioning this, but yes, I cannot agree more, of course.
Okay, now I think we should finish this session, and we'd like to thank all the speakers, and also first I would like to thank Dr. Mohammed Tajuddin for sharing the chairman with me, Dr. Khalid from Emirat for his very nice lectures, Dr. Lahibi from Saudi Arabia for update management of pancreatic fluid collections or drainage, الأستاذ الفاضل الدكتور علي فرج في دايما بيتعامل مع السمول انتستنز من كل حته، وهو المره دي حابب يتعامل معاها من بره ويحب يتعامل من جوه، النهارده يتعامل معاها من بره، وده معناه ان هو مش عارف يسيب السمول انتستن دي تطلع له هنا تطلع له هنا يعني. فالحقيقه موضوع جديد خالص، والحقيقه هو موضوع جديد انا عارف كويس قوي، لكن بقى عليه كلام في العالم جامد جدا في الفولو اب، قريب من الكال بروتكتين والحاجات زي كده. فهو يعني المحاضره يمكن مش باينه قوي دلوقتي، هي قويه جدا المحاضره، لكن الناس هتعرف قيمه الكلام اللي هو قاله ده بعد شويه لما يبقى ديت في الحاجات العاديه تتعمل. المحاضره اللي بعديها الدكتور حسام ادى فكره عامه، دخل في دبس قوي جدا بتاع الكرونيك بوليب، وبرضه ادى معلومه ان دي بوليب وبس، وقطعها ده موضوع خلاص بقى اوبسوليت، ما بقاش موجود. بقى النهارده ديتكت البوليب وديتكت دي كانسر ولا مش كانسر، دي عندها ديسبليزيا ولا مفيش فيها ديسبليزيا، قرب ما يتاخدش بايوبسي، دي اللي تعمل لها فولو اب البوليب اللي ما كانتش فيها ديتكشن اوف بوليب قد ايه. ده موضوع كبير جدا والعالم كله مهتم بيه، عشان بيقلل جامد قوي الكوريكتر كارسينوما اللي هي نمبر 5 في مصر اعتقد. الكوريكتر كارسينوما بتزيد قوي احنا مش عارفينها، لكن زي ما كنا قلنا محاضره الحالات كلها بتيجي عندنا فيري ليت، لا معاه ميتاستس في الليفر لا معاه ليمف نود، قليل قوي بنشوف عيان كوريكتر كانسرز بره، ما بقاش الكلام ده عشان السكريننج اللي بيتعمل. فدي مقدمه يمكن كويسه قوي على السكريننج. الجلسه كلها متكامله من الاساتذه ومن العلم، وبنشكر الدكتور حسين على تجميع هذا الفريق المتميز، ونشكر الاودينت، وهنسيب بقى الجلسه للدكتور حسين، لسه قدامكم جلستين اقوياء تكملوا معاهم باذن الله. ومتشكرين جدا، وكويس ان انا شفت الناس، متشكر الدكتور حسين جدا. السلام عليكم.